solvers. Prof. Res, at your service. How is everyone doing this morning? Give me a thumbs up if you are grateful for the day. Yes. We'll take it. Good. Welcome to another Friday edition of Virtual Morning Report. On Fridays, Robbie and I discuss an unknown together. It's a little bit of RLR. Reza loves Robbie. And I think Robbie's going to be joining us shortly, but we do have a case today, and it's presented by none other than Kirtan. Kirtan, do you mind sharing with the audience, reminding them where you are, what your interests are, what your long-term goals are?
Sure. So good morning, everyone. Myself, Kirtan Patolia. I am a final year medical student from BJ Medical College, Ahmedabad, which is in the western part of India. And I love internal medicine. I love our CP Solvers community. All of our student members team are so awesome. They help me amazingly. So I'm excited to present a case today. And as for my future goals, I am looking forward to apply for internal medicine residency during this med cycle. And I hope that I can do well.
Wow, Kirtan, you are going to do well. And I have to say, I'm so excited to discuss the case with Robbie. And I see Robbie is there. Robbie, do you mind unmuting yourself and saying hi to everyone as Valeria takes over the whiteboard?
Cool. Amazing. Hello, good morning, everybody. Without shampoo. I promised Prof. Rez would continue our shampoo saga. If you want to know more about the story, you should tune into the most recent RLR episode that came out yesterday. But that's the crux of my morning so far.
You know, Robbie, you've been bald for 2 days. I've been bald for a decade. You have to trust me, my friend. You're questioning me.
Sometimes you got to go with the beginner's perspective. Sometimes.
But not this time.
All right, you got it.
Robbie, your video is a little slow. Maybe turn off your video so that we can get your crisp audio. Go ahead and say a few words.
Do I sound good? Do I sound good now?
Guys, I'm going to kick Robbie off the VMR. I am the host and block him. We have a Zoom bomber. Listen, Kirtan, Robbie will tackle the first aliquot, and then we'll go from there, okay? Whenever you're ready, my friend.
All right. So the chief complaint is the dyspnea and lower extremity edema. Do you want me to give a bit of HPI too?
No, Kirtan, you've always, as always, set us up for success, and I think there's a lot to discuss here. And I can just tackle the chief concern and then pass the mic to Reza for the HPI. And the truth is, whenever you dyspnea and lower extremity edema are completely interrelated symptoms. And it's fascinating how whenever we hear both together, we assume that they're traveling in parallel. But since we've discussed that conversation and had that conversation before, I'll just point out that it's totally plausible that they're separate. It's totally plausible that somebody with chronic venous stasis has a new cardiopulmonary problem. It's also totally plausible that somebody with a chronic cardiopulmonary problem like COPD develops a separate cardiopulmonary problem resulting in shortness of breath or extremity edema. So you often have to be careful and understand, do these two things, do they come together and therefore are more likely to be associated? Or is there actually a disconnect in the time forcing you to actually develop separate schemas for each of them and trying to marry them? But here it's hard not to hear this complaint and go, oh, I know a very common cause of dyspnea and lower extremity edema, it's congestive heart failure. But it's also important to recognize that hepatic causes of lower extremity edema can result in shortness of breath, and so can nephrogenic causes of lower extremity edema resulting in shortness of breath. So here, the tremendous progress is to say that lower extremity edema has been found in conjunction with an accompanying symptom. So it's unlikely to be a disease isolated to the lower extremities like venous stasis. And any systemic cause of lower extremity edema is at play here. including cardiac, nephrogenic, and hepatic. And the priority should be to evaluate cardiac causes primarily because they're the most common, but also because the absence of jaundice makes liver disease less likely. And it's very, very hard to tease out nephrogenic causes of lower extremity edema without prioritizing cardiac causes. So that's where I'm at. And I'm curious for the HPI to help tease those out. But the biggest piece of advice is the more comfortable you get with this approach is to recognize that you're making the assumption that they're traveling together, which is a great assumption to start, but one that you should commit to until you have further data. All right, Kirtan, back to you.
Yes, so now a bit of HPI. So the patient is a 62-year-old female who presented with the history of facial and lower extremity edema and dyspnea since last 1 month. She also endorses anorexia, malaise, and profound fatigue since 1 month. As for the review of symptoms, she denies weight loss, fever, chills, night sweats, cough, chest pain, dizziness, headache, diarrhea, or abdominal pain. The past medical history is non-significant. She is on no medications. Family history is not relevant. As for the social history, she is a housewife and she denies alcohol, tobacco, or illicit drug use. And as for allergies, there are no allergies. And since there is not much in this aliquot, if you like, I can give you a physical examination too. All right. So for the physical examination, as for the vitals, the temperature was fine. The heart rate was 78 beats per minute. The BP was 104/72 millimeters of mercury. The oxygen saturation was 95% on room air, and the respiratory rate was 24. As for the general appearance, she was well and was conversant with us. And for the abdominal examination, the spleen was palpable. There was no evidence of tenderness, rigidity, or guarding. As for the cardiovascular examination, the S1 and S2 was fine. The rhythm was regular, and there was evidence of high-pitched holosystolic murmur at the left lower sternal border. So high-pitched holosystolic murmur at the left lower sternal border. Apart from that, the jugular venous pulse was elevated at 11 centimeters. For the pulmonary examination, there was no evidence of wheezes, crackles, or rhonchi. For the extremity examination, there was evidence of 2+ symmetric pitting edema bilaterally up to the level of shins. As for the neurological examination, her mental status was all right. She was oriented to time, place, and person. There was no deficits in cranial nerves, motor strength, and everything was fine. Reflexes were all right. And that concludes our aliquot number 2.
Kirtan, you're an expert presenter. Let me make sure that Valeria captured everything. Valeria, do you have any clarifying questions for Kirtan?
Sure.
Yeah, sorry, I didn't get what was the murmur, sorry?
Yes, so the murmur was high-pitched holosystolic murmur at the left lower sternal border.
Okay. Oh, and the
And
BP?
JVP was elevated, yeah. JVP was elevated at 11 centimeters of water.
Okay. And the blood pressure, sorry, what was the diastolic?
Yes, all right, let me check. Yeah, so it was 72 millimeters of mercury.
Sorry, can you repeat that? The
72,
pressure?
yeah, 72.
Okay, okay. Thank you.
Thank you, Valeria. So one of my favorite parts of Robbie's first discussion was using the term interrelated, and it was just beautiful watching him apply base rate of disease. I think this patient also had an enlarged spleen, if I'm not mistaken, Kirtan. So for the enlarged spleen, I want to, because it was palpable, a spleen shouldn't be palpable unless it's enlarged. And when it's even enlarged, it's difficult to palpate, and often we rely on imaging. But I'm going to ask Robbie to share his approach to splenomegaly in the context of this case. But I'm going to share a few thoughts regarding the HPI and the physical exam and the past medical stuff. Something very important is this. This patient has had 1 month of anorexia, malaise, and fatigue. What would you expect to happen to the weight of such a patient? It should go down, right? The fact that this patient hasn't lost any weight is probably explained by the volume overload. And whenever you have volume overload and you're not gaining weight, you have to think about a sinister process. You have to think about a sinister process. Think about all those patients that you take care of with congestive heart failure. One of your key review of system questions is, how much weight have you gained? Here, the patient hasn't gained any weight despite having anasarca, facial edema, lower extremity edema, jugular venous distension. So right away, I'm starting to think about inflammatory heart failure. I'm not going to activate that schema just yet. Mind you, patients with congestive heart failure for a long time can have cardiac cachexia, where you have increase in catabolism and muscle breakdown. So with regard to the HPI, really the only question to know if the patient has some kind of nephrotic syndrome is whether they have a frothy urine or not. But oftentimes we don't ask that, and oftentimes the patients don't volunteer that. So we're reliant on that urinalysis, which is assessing for albumin. And of course, you're going to want to know what a spot protein to creatinine ratio is. The fact that this patient has no known past medical history doesn't mean that they don't have illnesses that haven't been diagnosed yet. We don't know how plugged into care Kirtan's patient is. So no history doesn't mean no past medical history. Now, if we fast forward to the physical exam, right away, we look at the vital signs, and there's a couple of things to gather from the vital signs. One, this patient is tachypnic and is slightly hypoxemic, difficult to assess the 95%, which is consistent with this frame of volume overload. Interestingly, the heart rate isn't elevated. I would have expected a little bit of a higher heart rate, but this might be explained by the patient having these symptoms for a whole month. So whatever the process is, it's subacute to chronic. So the body has had a chance to compensate. You'll see this often with anemia 2, hemoglobin of 2, and the patient's heart rate is 65. You're like, wait, how is that even possible? When something is subacute and the body has a chance to respond, it's very good at establishing homeostasis. So now let's go. The question is, where is this volume coming from? We know we're dealing with a subacute to chronic process, and we're concerned for an inflammatory process despite the lack of fever by the fact that this patient hasn't gained weight. Right away, our attention comes to the heart. This is not a normal cardiac exam. So the question becomes, is the heart exam just a bystander, a red herring? I would say no. At this stage, this patient has heart failure, jugular venous distension, lower extremity edema, and maybe it's so severe that they also have facial edema. Although generally when we say facial edema specifically, like periorbital, we think more kidney. But here's a very important point. Just because you have a cardiac condition, does that exclude a renal cause? It does not. For example, amyloidosis, AL amyloid. It can involve the heart and the kidney. So this exam does not remove the kidney from Robbie's initial DDX. It removes it doesn't even necessarily remove the liver completely. More on that in a second, which I'll let Robbie talk about. But it confirms that the heart there's something going on there. Now, you might say the murmur, is this a primary valvular lesion causing tricuspid regurgitation in right-sided failure because this patient doesn't have crackles? You have to be very cautious there. When something is subacute to chronic with left-sided heart failure, the lymphatics compensate. So you actually might not auscultate crackles. You might not even see anything on imaging. And remember, if your heart is dilated, it can cause functional regurgitation. But we have to entertain both possibilities. Could this patient have subacute endocarditis causing heart failure, fatigue, malaise? It's possible. I can't make more progress on that. I'm open to the idea of even left-sided heart failure that's compensated. versus right-sided heart failure, whether it's tricuspid regurg, pulmonary hypertension. We're going to need more data to make more progress. That being said, I want to pass the mic to Robbie to not only incorporate the spleen, but authentically share his thoughts at this juncture.
It's just, it's, you know what I love about your discussion is how you're teaching while you discuss at the same time. And I love that point about when you find pathology somewhere that doesn't exclude an underlying contributor. When you find cardiac disease, how do you know the kidneys aren't contributing? And I think that's the tension here in this case is what is the cause and what is just hanging out. And I find I'm sharing that same struggle with the spleen. So let's talk about why the spleen is big. And let's just make it simple. The spleen is big because there's too much water in it, too many cells in it, or too many molecules in it. It really comes down to just that. And the truth is, water only builds up in the spleen when there's evidence of portal hypertension. And here, none. No kappa medusae, no spider angiomas, no ascites. It's probably not water, despite the fact that there's water everywhere else. So we're moving on to, is it accumulation of molecules or accumulation of cells? And that, unfortunately, is very hard to tell from the get-go. But examples of molecules are exactly what Reza said, amyloidosis, histiocytic diseases, so on and so forth. What kind of cells build up in the spleen? Red blood cells and white blood cells. And red blood cells are meant to signify chronic hemolytic disorders like hereditary spherocytosis or acute hemolytic disorders like malaria. No evidence of that here at all. I mean, we don't have the labs yet, but there's nothing to suggest anemia so far. And then the accumulation of white blood cells. Things like infections, like granulomatous diseases, autoimmune diseases like sarcoid, malignant cells like lymphoma or myeloproliferative disorders. And so here you're like, you know, let's just say this patient has heart failure. We have an elevated JVD, that tells you there's elevated cardiac pressures. The overlap between cardiac disease and splenic disease is not robust. You think about the number of people you've had heart failure. How many of those people with heart failure have turned out to have splenomegaly? It's unusual.
Zero.
That's right. So let's just play the game of why would somebody with heart failure get splenomegaly? Then maybe they get heart failure caused cardiac cirrhosis, and that causes portal hypertension. But again, there's no signs of cirrhosis here. Well, what if they have a high output cardiac failure from something like anemia, and the anemia can be connected to splenomegaly for many ways, like hemolysis or a chronic bone marrow problem or a chronic cancer. So that's probably the connection we can make. Or it could be because of the infiltration of the spleen and the heart by the same thing, and Reza mentioned this already, amyloidosis. But I would say the two most morbid causes acutely are endocarditis, which usually doesn't cause a big spleen, it causes an infarcted spleen, but maybe it's palpable because it's inflamed from the infarction. But I'd say most morbid of all is a malignancy like lymphoma affecting the spleen and affecting the heart primarily through the pericardium. So I would be, when I see splenomegaly in a patient with cardiac issues, I'm really worried about the possibility of pericardial effusion, because that's the simplest way I can connect a malignant process in the spleen, which it usually is, when the splenomegaly is without portal hypertension and without hectic inflammation, like a febrile splenomegaly process. But then, as the more I think about it, the more the esoteric comes to mind, where sarcoids infiltrate the spleen, infiltrate the heart. But let's stop. You don't get esoteric. The most morbid hypotheses here are endocarditis and a malignant process in the spleen of the heart. But we have to be anchored in the complexity of the cases Reza outlined and make sure we don't miss anything when making these assumptions. Anything to add to that, Rez?
Not, I love that, man. I, you know, from your entire discussion, I think that pericardial pathology would be a really nice unifying diagnosis here. So I'm very interested to see what the labs show. And I've already primed my mind to say, look, if this is constrictive pericardial disease, I don't expect to see a really high BNP. So we'll see what the data shows. But thanks for that, Robbie.
Yes. So you guys are on the right track as usual. So I will give you some labs. They are really interesting. So the hemoglobin was 4.8 grams per deciliter with mean corpuscular volume of 56. The WBC count was 3,100, so 3100. The platelet count was 134K. And all of these findings were recapitulated over a couple of days, and every time they stayed nearly these levels only. As for the basic metabolic panel, the sodium, potassium, chloride was all right. The bicarb, PCO2, BUN, creatinine was all right. As for the liver function test, the alkaline phosphatase was slightly elevated at 165. The albumin was low at 3 grams per deciliter. The total protein was low at 6 grams per deciliter. The ferritin was low at 3.7. I don't have the exact value for serum iron, but serum iron was low too. Same goes for copper as well as the vitamin D. Copper was low, vitamin D was low. I apologize for not having exact values, but they were low. As for the urine analysis was normal. So there was no evidence of proteinuria or no evidence of any casts. Apart from that, yes, the cholesterol was low at 101. The triglyceride was low at 30. The VLDL was low at 6. The LDL was low at 53. Let me repeat that. Cholesterol was 101. Triglyceride was 30. VLDL was 6. And LDL was 53. The CRP and ESR was normal. The thyroid function test, vitamin B12 levels, HIV, HbS-Ag was fine. The CKMB, troponin, and the pro-BNP levels were within the normal limits. Yes. And pro-BNP was normal too. Reza, do you want clarification on any of those?
Not me. Robbie, any clarification questions before you jump in?
What Kirtan has done is he has taken iron deficiency, wrapped it in a bow, and handed it to me. But let me explain how he did that. He told us that the patient is anemic and has microcytic. And I know he knows that only a few things cause microcytic anemia. Iron deficiency, thalassemia, and lead toxicity are the most common. But if you wanted to get esoteric, check out the schema on the website. And then he told us, whoa, the ferritin is low, which really confirms the presence of iron deficiency, but as Reza taught us, does not rule out contributions from thalassemia and does not rule out the possibility of lead toxicity. But now we know this patient's iron deficient for sure. And the question is, where did the iron go? And for that, I'll pass it to Reza and any other things.
I love that. So what Robbie just did is he took this complicated presentation, which had a very broad DDX, and just framed it as, why is this patient iron deficient? Because remember, even in the physical exam, Robbie said a way to tie everything together is potentially through high output heart failure. And right away, when you see anemia like this, and we know it's iron deficient, you ask the question, is it a slow process or is it a fast process? It's slow. This is like the normal pressure, the heart rate, all of that suggests is consistent with the HPI of like a 1 month, maybe even a longer process that has been brewing. I'll share my schema for iron deficiency, but first we have to ask the question, why is this patient tachypnic and hypoxemic? Because remember, even if your hemoglobin is low, it shouldn't affect your O2 sat. So I am interested in a chest x-ray for sure to see what the parenchyma looks like. But let's tackle iron deficiency. Does this case all funnel down to what's causing iron deficiency anemia in this patient? And note, you might be able to use deficiency of other elements to help prioritize the cause of iron deficiency anemia. I would say you really can't use vitamin D for anything because we're all vitamin D deficient. So I don't know how helpful that is, but copper seems a little more unique than vitamin D in trying to localize the lesion of the iron deficiency. So when you're dealing with iron deficiency, it comes down to really one of two things. And you got to start with base rate of disease, some kind of blood loss. And you can think blood loss from anywhere, from the GI tract, right? This patient is presumably postmenopausal. It will be very important to ask if she's having any vaginal bleeding. You have to think about the GI tract. For example, if there's a tumor, inflammatory bowel disease, you can lose iron in the lungs through diffuse alveolar hemorrhage. You can even lose iron from the skin when you have bed bugs causing phlebotomy. And sometimes patients may even sort of take their own blood and let out blood causing iron deficiency. But I think the first pass is there a GI loss of blood? Is there a vaginal loss of blood? Now, once we bypass the first pass of iron deficiency anemia, where we find ourselves is just follow the GI tract. So when you swallow food, it goes in the stomach. In the stomach, you need adequate acid secretion to free up the iron element. Here, the patient's not on a PPI, but if someone was on a PPI, for instance, that can lead to iron deficiency. For that case, listen to Robbie and I tackle a case with Bob Center. I'm sure Robbie knows the episode number, I don't, but that's one unique cause of iron deficiency. More common causes in the stomach, H. pylori, and autoimmune gastritis. Now, once you bypass the stomach and you start entering the intestines, here you can think about celiac disease, you can think about parasites, and you can think about anything that increases hepcidin, from CKD, genetic causes, heart failure. They can all lead to iron deficiency anemia. So Robbie, I'm going to pass the mic back to you, but where I am is first evaluate this patient's gastrointestinal tract, their GU tract, and if they're negative, if there's nothing to show us a GI blood loss, to then think about malabsorption, celiac disease, and far less common parasites, more common H. pylori and autoimmune gastritis.
Oh, beautiful, my dear friend, beautiful. I'm struggling now with anticipating how we're going to connect this to the splenomegaly. I'm just going to say that. How are we going to connect this to the splenomegaly? Very tricky connection now. I know that patients with, you probably could have a small bowel lymphoma maybe, or you could have celiac disease cause splenomegaly, but I don't know. I don't know where I'm trying to be ahead of this case, and I'm struggling just to put that out there. Like, what could we find here that connects to splenomegaly? And really interesting I can't come up with that in a way that's efficient or quick, and I cannot wait to learn that. But I want to throw that back out to you. If we try to see how could we tie iron deficiency to splenomegaly, and I'm not sure if I can come up with something, but maybe a riddle for us to process slowly.
I love it.
Kirtan. Oh, yeah.
No, I was just saying I love it and I'm ready. I too am right where you are, Robbie.
Alrighty, Kirtan, tell us how this story evolves.
Yes. So for the aliquot number 4, I will give you some imaging findings. So we did the ultrasonography and there was evidence of prominent hepatic vein and inferior vena cava. There was bulky spleen. So as per the USG report, it was +2 splenomegaly. Apart from that, there was evidence of dilated, tortuous, intrahepatic, periportal, and splenic collaterals suggestive of chronic congestion. Apart from that, the chest X-ray was all right. They did the colonoscopy to see the evidence of colorectal cancer or any other evidence of mucosal erosions, but the colonoscopy was clear. For the echocardiography, there was severe tricuspid regurgitation without any evidence of pulmonary hypertension or other valvular disorder. And I think the next aliquot will reveal the final diagnosis.
Kirtan, one question for you. Was the
Yes.
right ventricle also dilated?
So no, there was no evidence of dilatation of right ventricle, and all the dimensions, so the thickness of the chamber itself and the total dimension of the chamber were all good within the normal limits.
Boy, Robbie, I'm going to need your help here, my friend. So
I don't know. I'm breaking down in a sweat. So
let's tackle this one at a time. Like what I gather from this ultrasound showing sort of dilated venous system is exactly what Kirtan said, chronic congestion leading, I think let's ignore the iron deficiency for 1 second, right? By the way, when someone's MCV is that low, you should also think about maybe undiagnosed thalassemia. There's no reason you can't have thalassemia with iron deficiency, but that's maybe one of the lowest MCVs I've seen. You can look at the mean corpuscular hemoglobin concentration. That could help you out to see if there might be thalassemia. But I'm sorry, you can look at the Menser index. My thing is this: if we remove iron deficiency anemia and we just say this is all chronic congestion, now our job is trying to identify why does this patient have congestive heart failure that's been going on for so long. And what we have is this echocardiogram showing severe tricuspid regurgitation without right ventricle dilation. Now, I just want to explain this to the audience. Sometimes patients will develop heart failure. They'll get cardiac remodeling. And in that process, as that ventricle stretches out, it stretches out the valve as well. And that results in regurgitant flow or the murmur that you auscultate. But here, when Kirtan is saying that the ventricle is normal in size, now I'm worried about primary pathology of that tricuspid valve. Primary pathology of the tricuspid valve. And I know this is really far-fetched, but I think Robbie once taught me that you can even have hemolysis from, you can have iron deficiency anemia from intravascular hemolysis. Robbie will fact check that statement. So I'm just now reviewing the labs again to make sure that the bilirubin wasn't up, the haptoglobin wasn't down, because I'm trying to link the two together. But in my mind right now, Robbie, I want to ask the question, yes, I mean, the iron deficiency is interesting, but I want to say, why does this patient have severe tricuspid regurg? Because if we frame it from that perspective, it seems like the final diagnosis must explain that, because I think that's what's leading to the splenomegaly, the collateral veins, and the congestion that Kirtan pointed out on the ultrasound. And when I think of valvular regurgitation, I ask the question, was there an ischemic event? Is there a vegetation? Was there some kind of trauma that led to that regurgitation? And you might say, well, if there's a vegetation, why didn't we see it? Well, remember, the TTE has to shoot through the sternum. So the sternum obstructs what the ultrasound can do. And that's why we proceed with the transesophageal echocardiogram. So for me right now, I really want to understand why this patient has severe tricuspid regurgitation. And like I said, is there endocarditis that we haven't diagnosed? Was there some kind of ischemic event in the past? It doesn't seem so based on the electrocardiogram. There was no trauma. But Robbie, what history of rheumatic disease, et cetera? What do you have to add, my friend?
I don't know. Here's what I can say. I think what you're doing is really what we can do. The only truth in medicine is trying to represent the problem before you. And then what conclusion you come to is based on probability. And this case is one that features lower extremity edema, anorexia, weight loss, splenomegaly, iron deficiency anemia, copper deficiency, and vitamin D deficiency. And what you're telling us is that you believe that a lot of them collapse into valvular heart failure, that the spleen problem, the edema, the JVP, facial edema, all are explained by a lesion right there in the tricuspid valve. And then you taught us a valvular regurgitation doesn't mean a problem in the valve. That's why it's important to know what's the status of the RV. If the RV is dilated, that is probably causing the valve problem. That's where you taught us, listen, if you answer what is causing the valvular heart failure, you'll answer the most, you'll put together many things. You'll put together the splenomegaly and the edema. And that for a second leaves us like, okay, what is not readily explained? And I think the iron deficiency anemia is not readily explained. And maybe the hypoalbuminemia is not readily explained. And maybe the alk phos is not readily explained. Though you could say whoever is sick for months will have a low albumin. And when somebody is just congested, their alk phos is high. That's fine. So maybe the exercise is, okay, well, what are the causes of tricuspid insufficiency? And I'm just going to say them out loud for repetition. It really is whatever, all the diseases that affect all the valves, which is rheumatic heart disease and endocarditis. Like endocarditis and rheumatic heart disease affect every single valve. And here, rheumatic heart disease is unlikely in this patient because of the distribution of the valves and her age. And endocarditis is unlikely now, but maybe she had a remote episode of endocarditis, or maybe she has culture negative endocarditis. So those are things we have to think about. What are diseases that affect just the tricuspid valve alone? And the tricuspid valve is vulnerable to trauma, from external trauma, like hitting your chest against something. It's vulnerable to intravascular lines, like pacemakers or central lines obstructing its function. And most uniquely of all, it's vulnerable to carcinoid syndrome. And here you ask yourself, hey, is there a case for carcinoid here? And on first glance, the answer is heck no. There's no wheezing, there's no diarrhea, and there's no flushing. But you wonder, hey, is this an atypical presentation of otherwise clinically silent carcinoid? Because you can't come up with a quick explanation for why the tricuspid valve is otherwise affected. But if you could come up with a reason for why you have tricuspid insufficiency, you'd probably forget about carcinoid. But here, I'd probably put the spotlight on carcinoid for two reasons. One, it's hard to come up with an explanation for the TR, and two, there's a signal to pathology in the GI tract that you alluded to already. So I'm starting to worry about carcinoid for that reason. But, you can connect heart failure to iron deficiency anemia through the shearing of von Willebrand's factor. In fact, a lot of patients with heart failure are iron deficient. You could also connect heart failure with GI pathology through protein losing enteropathy. And just like the spleen is swollen and the legs are swollen, the GI tract can become swollen, cause iron deficiency, low albumin, low total protein. So could this patient have protein losing enteropathy from the heart failure? So, I don't know. I've struggled to come up with a disease that elegantly explains everything, but I agree with you. I bet whatever this disease is, it probably causes tricuspid insufficiency, uniquely so. And is it just carcinoid, or is it an unexplainable or hard to explain cause of TR that causes non-specific disease in the GI tract, like iron deficiency or protein losing enteropathy? I'm not sure I can confidently say what the answer is, but I agree with you that the spotlight should be what is the cause of tricuspid insufficiency. I'll hand it back to you to see if you've had any thoughts surface since I've been rambling for a while.
The one thought I have is I am just so impressed to look at this data and invoke the possibility of carcinoid. It just shows your comfort with that rare diagnostic entity. And I love that hypothesis. And I love the addition of just vegetation and shearing of von Willebrand's leading to GI loss. I thought both those points, Robbie, beautiful points. And I'm very interested to hear from Kirtan what happened next. If I were taking care of this patient, my next move would be a transesophageal echocardiogram. But I've been wrong many times before. We'll see what Kirtan teaches us.
Yes, so actually you and Ravi got it. You are on the right track. So actually, when I first saw this patient, the most striking thing was the low lipid levels. I mean, if you see the VLDL and LDL, they are barely present. So the extremely low lipid levels combined with the presence of copper deficiency and probably even vitamin D deficiency, given the elevation in alkaline phosphatase level, I was even worried about the possibility of protein losing enteropathy. And the thing was that once we have something wrong with the heart, let's say constrictive pericarditis or tricuspid regurgitation, and you can get what is known as lymphangiectasia of the intestinal wall. So the whole lymphatic system kind of swells up. And when that lymphatic swells up in the intestinal wall, those lymphatic gets dilated and you start losing everything from that. You will start losing lymphocytes. You will start losing all the proteins. You will start losing all the fat, chylomicrons, everything. So that is one of the reasons why patients' WBC are so low, because if you lose the lymphocyte itself from the wall, then that can explain the lymphopenia part. And of course, the total protein was also low, which means the immunoglobulins are also low. So if you have hypogammaglobulinemia, that can also be explained by that. And as Rabi astutely pointed out, that right heart failure can cause protein-losing enteropathy. And this is the mechanism for that, lymphangiectasia. So for that purpose, we ordered the serum alpha-1 antitrypsin levels, and they were extremely elevated, suggestive of malabsorption, suggestive of protein-losing enteropathy. So the final diagnosis was protein-losing enteropathy causing secondary intestinal lymphangiectasia because of the severe tricapsid regurgitation. Once we proposed this idea to our cardiology team, they did the transesophageal echo and they find the evidence of scarring on the tricapsid wall, suggesting of the rheumatic heart disease, which our friends in the chat mentioned long way back, that rheumatic heart disease, and even Rabi and you mentioned that rheumatic heart disease is very common cause in India too. So that was the final diagnosis: rheumatic heart disease causing tricapsid regurgitation, that causing enteropathy, that causing lymphangiectasia, and that causing everything. And for the treatment plan, we know that we have to treat the underlying cause. So we consulted the cardiology team. They thought that it might be difficult to handle the tricapsid regurgitation, which is this much severe, but they can look into it. And meanwhile, we advised the patient to go on a low fat diet, especially consisting of medium chain fatty acids, because they can be absorbed easily, they can bypass the lymphatics. And we advise the patient to consume as much as low salt as possible, so probably less than 2 grams or 1 grams per day. And on follow-up examination after 15 days, the edema had resolved, not much, but from +2 1, it was now +1 edema, and she was no longer dyspneic, and she was doing great.
I can't wait to hear Robbie's thoughts on this, but Kirtan, like, that was phenomenal. Oh my gosh. I wish you could, I have goosebumps right now. What a case. That is like an NEJM worthy clinical problem solving exercise. And I just want to applaud your understanding of pathophysiology. That was poetic, Kirtan. I'm going to watch this later this weekend to just absorb all of your teaching. Phenomenal case. Robbie, thoughts before Kiara or Kirtan, take it over?
Such a delight. I think, I don't know, I keep going back to recognizing just the power of making sure that you represent the problem correctly. And for me, I was actually a little bit lost. And when I heard you kind of distill it down to what is the problem with the tricuspid valve, and that to me like gives you a launching pad for clarity. So I encourage you all, when you're struggling, just to be like, well, what is the real problem here? And the problem was made so much simpler, although it was incredibly hard. It was made simpler by lumping in almost everything into what is the cause of heart failure in this patient, by lumping in the spleen, lumping in the edema, lumping in everything. And it turns out through Kirtan's expertise and wisdom that actually everything lumped in to congestive heart failure, including the stuff that we had a harder time lumping in, the protein-losing enteropathy. So everything in this case comes down to what is the cause of the tricuspid insufficiency. And I think that's just amazing. And sometimes it takes a lot of dedicated practice to know about protein-losing enteropathy and to learn about it. But it's humbling if you continue on the journey of what is the real problem here. Everything was explained by the tricuspid regurg, both through more common knowledge, like lower extremity edema, and then harder to obtain and more effortful knowledge, like protein-losing enteropathy. So I'm just humbled by this case and how complex it is in many ways, but how simple it is in many ways. It's one thing in the person's chest is causing all the devastation everywhere else. So kudos to you, Kirtan, for recognizing the simplicity and the complexity of it. It's a joy to break it down for you all today. All right, Kiara, take us home, my friend.
I'm just speechless because you don't know how much I love cardiology, but learning something new in cardiology is like the best feeling in the world. So thank you so much, Kirtan. And well, we can start with this elderly patient that presents with dyspnea and lower extremity edema. And Ravi first told us that this dyspnea and lower extremity edema we can have two scenarios. First, this can be interrelated or this can be two separate entities. But the most common thing is that these two are interrelated and probably this is a cardiogenic cause. Then we knew that we had an important pearl that when we have a patient with volume overload, but this patient isn't gaining weight, we have to think about many sinister causes. First, maybe some inflammatory heart failure that can be causing some kind of cardiac cachexia. Then we had on physical exam that this patient had a new holosystolic murmur in the left lower sternum. So this we were focusing on the tricuspid area. So probably this was a tricuspid regurgitation most commonly, or a ventricular septal defect that we can also hear a murmur, this characteristic murmur in this part. So Reza told us that this can be two things too. One, this can be a left-sided heart failure, which is compensated. I put here decompensated, but this can be a left-sided compensated heart failure when the lymphatics like get dilated and they compensate this volume overload, or this can be a right-sided pathology itself. Then we had that this patient had splenomegaly, and one of my favorite schemas in the world is Ravi's schemas teaching about splenomegaly because this is so organized in three important parts. One is this can be water causes, most commonly like in portal hypertension. So we have to look for some stigmas for portal hypertension in the patient that we didn't find that things in these patients. Then this can be molecules, and this can also be due to cells. Which cells? Red blood cells or white blood cells. If it is due to red blood cells, this can be like genetic, like thalassemia or some kind of spherocytosis or any kind of genetic causes causing this splenomegaly, or infections affecting the blood cells like malaria or babesia. Then we can have problems in the white blood cells, and this is like a more broad diagnosis that can be due to infections, myeloproliferative diseases, malignancies, autoimmune, or many drugs. Then how we can like mix heart failure with splenomegaly. Again, we have to think about cardiac cirrhosis. Then we have to think about high output heart failure, like causing anemia, causing this high output heart failure, infiltration diseases like amyloidosis, sarcoidosis, endocarditis, causing like spleen infarcts, or some malignancies like lymphoma. Then we had that this patient had lab test positive for iron deficiency anemia. So Reza told us that this can happen like low process causing iron deficiency anemia, or any fast process. But it's better to start like one according to base rate because blood loss is most common. So we can start thinking about the GI tract. Maybe this is a tumor, inflammatory bowel disease, pulmonary diffuse alveolar hemorrhage, or postmenopausal patient which is losing blood, maybe somehow. But we can also starting with the stomach and going through all the GI tract, because we know that losing iron, this can be due to H. pylori, gastritic, less common celiac disease, or some parasites. Then to end these teaching points, we had that this patient had a severe tricuspid regurgitation. But the important and curious thing is that this patient didn't had right ventricular dilation like in compensation. So this we have to, when we don't have this kind of compensation, we have to think about some primary disease affecting this valve. So maybe this was due to some ischemia, some external trauma, because valves can be propensity to traumas external or intravascular trauma like catheters or carcinoid syndrome. However, this patient didn't have symptoms or signs for carcinoid syndrome. Maybe some vegetations, like in this case, wow, Kieran. Like in this case, this patient had rheumatic disease or endocarditis, and we have to check this not with a TE because the sternum, like, avoid having an accurate diagnosis for some valve disease. We also have to check bilirubin because this iron deficiency anemia could be caused by some intravascular hemolysis because of the valve disease. So we also have to think if this patient is hemolyzing. But it was nothing about here, and we were so close, but at the time we were so far, and it was like some protein loss enteropathy. Well, we start with the valve disease causing many things and losing everything due to this. Wow, this is amazing. Thank you so much, Kieran and Ravi and Reza. You're amazing.
Phenomenal job, Kiara. As always, such a pleasure to listen to you teach. Thank you, Kirtan. Robbie, I hope you have a great trip, and we will see you next time. Thank you. Bye.